Hi, Insta family. It's Tamara here. Lovely to see you. Welcome back to me from holidays. How are you guys? I've actually really missed you. I hope you've had a wonderful couple of weeks. I certainly have. I've been away on a little trip. Rather nice. I might share some of my holiday snaps with you. Definitely somewhere I would recommend. And I had some beautiful time off with my children. Just an opportunity to be present, which I think as a working mama is super important. So lovely to see all you guys jumping on. Thank you. All right, do you know what? I've just spent the last 5 odd minutes going through all my DMs. There were so many requests for answers to questions. And I probably only have about 10 minutes of battery power left. So the first thing I want to do, I feel like a wiggle, but the first thing that I want to do is say to Jordan, if you are listening, Jordan, congratulations on the birth of beautiful Jet. Well done. Thank you very much for your beautiful pictures. They're always appreciated. They give me the best warm fuzzies. So congratulations. Now, questions. Don't forget to pop any rapid fire questions that you might have into the little chat box. You may or may not know we have some rules. If you can make these questions as generic as possible, I don't need your whole life story. Keep it short and sweet. I'll be keeping the answers short and sweet and as generic as I possibly can. But feel free over the next 10 odd minutes for you to drop some little questions in the Q&A. But I do have some to get us going. Now, somebody just asked the question around, actually there's quite a varied amount of questions here. So I'm going to start with this one. Someone asked me the question, I'm 47 years of age. I haven't had the opportunity to have my own children. What's my chances of success with my own eggs? Should I be looking for someone who has younger eggs to donate? And look, my short and sweet answer is it completely impossible to conceive if you're still having a menstrual cycle? Is it completely impossible to conceive spontaneously at the age of 47? No, it's not. It's a very low chance, but it's not completely impossible. Is it possible to conceive using assisted reproduction, i.e. IVF, with your own eggs at 47? Also, extremely low chance. In fact, they've done mathematical modelling, and the mathematical modelling has suggested that it would take about 80 IVF cycles for a woman to conceive using her own autologous, her own eggs at over the age of 45. So the chances are pretty low. Let's say, 1 in 500. But for some people, they may turn around and say, well, that's a chance then. I want to give it a go. But the only thing I would say is falling pregnant as an older woman or being pregnant as an older woman is not without complication. There are significantly higher chances of preeclampsia, gestational diabetes, cesarean delivery, preterm birth, neonatal issues, stillbirth, and so on. So it is absolutely important that your fertility specialist refers you off to see an obstetric physician. In fact, most of my patients over the age of 43, 44 are being referred off to an obstetric physician to just ensure that they are in their tip-top condition. Now, you may be yoga loving and hydroponically eating and think you look after your temple, that's great, but your body has reserves, and it's really important that a physician a clever doctor who understands the changes in pregnancy has a look and gives you a once-over. So it's just really important for you to understand that, okay, even if you fell pregnant with a donor egg and you're 45, 46, 47, your pregnancy has a high risk of complications and you must be well monitored. All right, that's for a spiel on that one. Somebody else has asked the question about different types of polycystic ovarian syndrome. And right off the bat, I was like, yeah, let me tell you about it. Until they further ask the question, can the pill induce PCOS? And the simple answer to that is no. No, the pill doesn't induce PCOS. Polycystic ovarian syndrome is exactly that. It's a cluster of symptoms. In fact, there's a criteria. The most common one used is the Rotterdam criteria. And you need to have 2 out of 3 of the following characteristics to be PCOS. very irregular cycles. We call this oligoanovulation or oligoamenorrhea, where you might have a cycle 2-3 months apart, right? Not just 1 month it's 35 days and the next month it's 28 days. Not that kind of irregular. I'm talking months apart. So you've got to have that. You've got to have an ultrasound that has polycystic ovarian appearance of the ovaries, and there's certain criteria that you have to satisfy. I'm not going to go into it. And then the third thing is either clinical or biochemical blood test evidence of high levels of male hormone. So we call that hyperandrogenism. So a clinical evidence of high levels of male hormone might be a bit of facial acne, a bit of bacne, maybe a few hairs here, on the chest, on the tummy, snail trail. Or evidence on a blood test of high levels of male hormone. And you've got to have 2 out of 3 of those to be classified as polycystic ovarian syndrome. Now, you've got your classic PCOS woman who tends to be a bit centrally overweight, might have quite significant features of hair growth or acne. And then you've got your non-classical, what I call skinny PCOS, who kind of have optimized their lifestyle as much as possible, but they've still got these highly irregular cycles. Now, although on a blood test, it might appear, sorry, I'm almost running out of battery. It might appear they don't have insulin resistance. They probably actually do, which is why, even though they've optimized their lifestyle as much as possible, they are still having issues with periods. So they're the ones that we tend to encourage to go on metformin. Is there evidence-based lifestyle guidelines? 100%. And I would encourage you, without me going into them on here, I would encourage you to go and have a look at the Jean Hales Foundation. Hales is spelled Hailes. Jean is spelled Jean. Jean Hales Foundation. They have a plethora of evidence-based information around lifestyle intervention to help improve outcomes for pregnancy and life with someone who has PCOS. All right, someone else has asked the question about endocrine disruptors. What do I know about endocrine disruptors, Dr. Maddie? And do I think that they're significant in the context of reproductive health? 100% I agree that they are they are impactful. So what is an endocrine disruptor? Endocrine disruptors are chemicals that disrupt the endocrine receptors. So they might block endocrine receptors in the body. And the most common that we know of are plasticizers. So things that make plastics really soft are endocrine disruptors. Something you might know about is BPA. You might have heard of that one. But there's a whole heap of others. I can't even remember them all. So here's the thing about endocrine disruptors. They are ubiquitous in our environment. They're all around us in the things that we touch, in the things that we put on our face. They're in makeup, they're in hair dye. So we're kind of all exposed to them. Some of us a bit more than others, but definitely in plastics. Now, there is fairly robust evidence to show that endocrine disruptor exposure for males can increase the chances of something called testicular dysgenesis syndrome, which is where there is an abnormality in the development of the penile urethra, potentially the testes don't descend, and an increased risk of testicular cancer, plus abnormal semen analysis results. So we definitely know with boys, biological males that are exposed to endocrine disruptors, there's that increased risk of testicular dysgenesis. There is also some evidence out of the RAIN study that there may be some impacts on female fertility as well, though it's a little bit more vague. But do I think endocrine disruptors are impactful in reproductive health? 100% hell yeah. Should we all try to decrease our exposure to them? Yeah, but it is difficult. It is difficult, particularly as a woman who likes to wear makeup, to reduce your exposure to endocrine disruptors. All right, I hope you guys are finding this helpful. Someone on here has asked another question, and my battery's going. Emma Green, is there any studies or anecdotal evidence that having COVID can affect your menstrual cycle? Yes, actually. There is some working groups, I think over on the East Coast and internationally, that are looking at how having COVID and or having COVID vaccination can potentially disrupt just acutely, not long term, the menstrual cycle. So certainly anecdotally, I have definitely come across it. As far as published evidence, I suspect there will be some emerging. I haven't actively seen anything, though I'm not looking that hard at the moment. But I do think that it will emerge that there potentially was some short-term impacts. We also know that there are some short-term impacts on sperm parameters in men who were previously normally fertile. So we do think that COVID has some impact on systemic reproductive health. Good question. Okay. Oh, here's some more. Melina, how are you, my love? If you have PCOS, how long after birth should your cycle start? Well, I guess it depends if you're breastfeeding. Breastfeeding is kind of your natural contraceptive because your high levels of prolactin will suppress your cycles. So until you stop breastfeeding, it's very difficult to tell. I think once you've stopped breastfeeding and you're not on any hormonal contraception, even the progesterone only kind, if you have not had a return to cycle by about, 3 months and you have a known history of PCOS, I would probably go and get investigated, particularly if you are wanting to conceive again, or you are finding other symptoms associated with PCOS, such as hyperandrogenism, are coming out again. Sparklin 786, how long metformin for ovulation? Taking it for a year now. Okay. I guess it depends on why you're taking metformin. It is not an ovulation induction agent. So it's not a medication that I give you and say, this will make you ovulate. It is used as an adjuvant, so an assistance to help reduce the, relative insulin resistance. Plus there's some other mechanisms that we don't really understand how it works, but we use it as an adjuvant to ovulation induction treatment. So if you had PCOS and the only thing you needed was to ovulate, to conceive, I would pop you on metformin, and then I would do ovulation induction with one of the various agents, letrozole, Clomid, gonadotrophins, whatever your poison, whatever the particular fertility specialist. But I would not be giving you metformin as an ovulation induction agent. When you talk about long-term side effects, there's no long-term negative side effects, but you can have some acute side effects with gut upset and a little bit of bowel hurry. But if you think about it, diabetic populations use it long-term to combat insulin resistance. So it is a drug that is safe to use in the long term, but if you're using it for the intention of trying to get pregnant, don't rely on it in isolation. Oh, my battery's nearly done. Are older parents more likely to conceive a certain sex? Someone else just posed this in a little DM to me, actually. I'm wondering if it's the same person. I don't think so. I don't think so. To be honest, I've got to tell you, I haven't actually done the research on this. And what's older? Like, is older 40 or is it 45 or is it over 38? Like, what's older? And is there a component that's male? Obviously the gender is determined by the sperm. So is it the age of the man? I don't know. It's a really great question. Read an article. Was it a scientific article or was it in a magazine? I don't know. It's a great question though. I might have to go look that one up. I'm actually stumped by that. Lots of confounders though, I think, in that. Quick question, Shalik. What is your say on taking protein shakes? Protein shakes generally or protein shakes in the context of fertility? Though protein, I guess a protein shake has some protein in it. It's got a little bit of carbs, a little bit of fat, probably not much of those two, but most protein shakes either come from a whey protein isolate or they come from a plant-based protein. Look, as long as you're not overdosing, but I don't think the impact is on fertility. I think the impact would be more on renal health. So if you're overdosing on protein, your kidneys have got to process that stuff. So from a fertility point of view, no, I don't think a protein shake, as long as that's all it's got in it and doesn't have any steroidy stuff, then I think you should be fine. Hey, these were some really great questions. Let me see. I'm going to wrap it up because, of course, I've gone way over 10 minutes like I always do. Just quickly, someone has asked a question about LH surge and ovulation testing kits, and she's noticed a 5 days of an LH surge. What you've got to understand is that the ovulation testing kits are testing the metabolites of the hormones. So they're testing the metabolites of your LH, right? And the LH can go up over a couple of days and then it drops down. 5 days is a long time. I'd be interested to see what the cycles were like, I guess, ongoing. Do you have variable cycles? Are we sort of testing a situation where you might have tonically elevated LH in the context of PCOS? If it's a one-off, I wouldn't worry too much about it. But it's also how you're interpreting it. Are you interpreting the really strong line or just the subtle increase as it slowly rises up over a few days? Often it's a good idea, if you're not completely trusting of your ovulation testing kit, is to run it next to a lab managed tracking cycle where the laboratory actually does the blood tests for you and tells you when to have what frequency to have them done, and then tells you how to time intercourse. You can run that side by side with an ovulation testing kit and just see how it compares. I think that's quite a neat little exercise that you can do. Well, guys, I'm hoping that I have answered most of your questions. There's a few more. Someone asked some questions about menopause hormone therapy, but that's a whole nother ball game. That's a whole nother Q&A live. Lovely to see you guys. I'm going to wrap it up now. Thank you once again for hopping on. There's lots of lovely faces. Emma and Jane, lovely to see you again. Katie and James, Beaton's Bell, Naomi, Rach, Peripolitis, good to see you again. Lovely to see you guys. I feel like I've come home. Good to see you. Stay well for the rest of the week. I'm off to Sydney on Thursday for a little meeting, and I will be back online. Now, next Tuesday, that will be the 18th. I am presenting around Slinder contraception with my beautiful colleague, Dr. Sunita Shelva, who'll be talking about menopause hormone therapy. We are actually presenting at a GP medical conference. So let's make a pact that next Tuesday we will do Wednesday night instead. Let's do Wednesday night Q&A instead of Tuesday night. Put that one in the diary. I'll make sure Shani knows to put a little sign up that says we're going to do our Q&A on Wednesday night because Tamara's busy. Tomorrow's busy on Tuesday night. Have a beautiful week, guys. All the best. Look after yourselves. Look after each other. Be kind. Have a great week. See you soon.